Have you ever looked at your horse and just, noticed something a little off? Maybe they're sluggish or their coat isn't quite right.
Yeah, it happens all the time.
And then you go through the whole vet visit, the tests, and suddenly you're looking at this printout. Complex hormone levels, low T4, high ACTH. What does it all mean?
It can feel like you're just drowning in data,
Right.
and everyone seems to have different advice.
Totally. Well, today we're diving deep into exactly that. The pretty complex world of equine thyroid and pituitary hormone testing. We want to cut through all that noise and get to the really important stuff, some facts that might even surprise you. Think of it as getting you properly informed.
That's the plan. Our mission here is really to walk you through what the comprehensive sources say about this testing. We'll look at the actual physiology,
Okay.
bust some common myths that, honestly, even vets and experienced owners sometimes fall for, and really highlight the critical details and diagnoses that often get missed.
So it's not just about disease.
No, not at all. It's about appreciating the horse's whole health picture, that sort of physiological symphony going on inside them.
Okay, let's unpack this then, starting right at the beginning. The equine endocrine system.
The foundation.
Yeah, imagine it like this sophisticated internal orchestra inside your horse. You've got glands, hormones. They're running everything. Metabolism, growth, reproduction, stress response.
They're the chemical messengers.
Yeah,
Absolutely essential for keeping everything in balance, what we call homeostasis.
and that balance is key.
It is, and that's why getting diagnoses right when it comes to endocrine disorders is just so critical. Any disruption, well, can have huge effects on health, on performance.
And getting it wrong.
That's risky. You end up with treatments that don't work, or worse, make things worse. The horse suffers longer, conditions can be exacerbated, and frankly, it costs owners a lot of money and stress when they're just trying to help their animal.
Okay, so let's focus on one key player in that orchestra. The thyroid gland, often called the metabolic maestro, right?
That's a good way to put it.
Its main hormones are T4, thyroxine, and T3, triiodothyronine. T4 is like the storage form. Longer half-life, about a week.
Yeah, it's the prohormone. T3 is the much more metabolically active one, but doesn't hang around as long, maybe a day or so.
And most T3 actually comes from T4 being converted elsewhere in the body.
Exactly, in the peripheral tissues, by these enzymes called deiodinases. And then there's also this inactive form, reverse T3, or RT3, made from T4 too.
So how is all this controlled? It sounds complicated.
It is pretty intricate. It's managed by what we call the hypothalamic pituitary thyroid axis, the HPT axis.
Okay.
So think of it like a chain reaction. TRH from the hypothalamus tells the pituitary to release TSH, then TSH tells the thyroid to release T3 and T4.
Right.
And because these thyroid hormones affect nearly every metabolic process, even a small imbalance can have these widespread but often really subtle effects. Performance, recovery, even how susceptible they are to other issues.
So interpreting those basic levels isn't straightforward.
Not at all. It's inherently complex. You really need to look closer.
Now, here's where it gets really interesting for me, and probably for a lot of listeners. For years, if a horse seemed off, maybe sluggish or overweight, the first thought was often thyroid problem.
That was definitely a common assumption.
But the research, the data we have now, it tells a different story, doesn't it? True primary hypothyroidism, where the thyroid itself isn't working, and hyperthyroidism, they're actually, exceptionally rare.
Exceptionally rare or uncommon diagnoses. Yes, that's accurate based on current understanding. It really challenges that old way of thinking.
So what are the signs when that rare primary hypothyroidism does happen?
Well, the actual clinical signs are usually things like lethargy. They just don't have the same exercise tolerance, maybe a poor, coarse hair coat.
Not necessarily obesity or laminitis then. Those are often linked anecdotally.
Right. And that's a key point. Those common associations, obesity, laminitis, even infertility, they're largely unsupported by the research. Studies where they actually removed the thyroid gland in horses, those horses did not gain weight or develop laminitis.
Wow. So the low thyroid levels people see are often secondary.
Exactly. Far more often, they're a consequence of some other illness or issue going on, not a primary failure of the gland itself. It flips the script.
And the flip side, hyperthyroidism, also rare.
Also very rare. Signs there would be more like unexplained weight loss, even though they're eating well, polyphagia, muscle wasting, maybe a high heart rate or breathing rate, poor coat, sometimes behavioral changes.
And that's usually caused by tumors.
In most of those rare cases, yes. functional thyroid tumors.
Okay, so why is knowing how rare these primary conditions are so important?
Because overdiagnosing them based on, vague signs or just one low reading leads to problems. You get horses put on thyroid supplements they don't need.
Which isn't just ineffective, but potentially harmful.
Potentially, yes. Giving unnecessary little thyroxine, for example, can increase the risk of things like cardiac arrhythmias. It really highlights why vets need strict diagnostic protocols and good client communication. We have to be sure treatment is actually warranted.
Right. So if those basic blood tests can be tricky, how do we properly assess thyroid function? We start with measuring total T4 and total T3.
Often, yes. There are initial screening tools. Total T4 gives a general picture, and it's also used for monitoring supplementation. You draw blood maybe 2 to 8 hours after they get their meds. Serum is usually preferred for T4.
But that's not the whole story. There's a better test.
There is. The crucial test is free T4 by equilibrium dialysis, FT4D.
Why is that one so much better?
Because it does a much better job of separating true thyroid issues from changes caused by other things, medications, diet, illness, you name it. It's really the only reliable free T4 method validated for horses.
Okay.
And interestingly, FT4 isn't really affected by supplementation, so you can't use it to monitor treatment. But, and this is critical FT4 can read falsely high if the sample gets warm. So careful handling, keeping it chilled, is vital.
Got it. Chilled sample for FT4D. What about stimulation tests? I've heard of the TRH stim test for thyroid.
Yes, the thyrotropin-releasing hormone, or TRH, stimulation test. Its real value is testing the whole HPT axis, that entire feedback loop. It basically asks the thyroid gland, are you responding properly to the signals?
How does that work?
You take a baseline blood sample for T3 and T4. Then you give TRH intravenously, the dose based on weight. Then you take more samples at specific times, usually 2 hours later for T3 and 4 hours later for T4.
And what shows a normal response?
A normal, healthy thyroid will show a significant jump, usually defined as more than 1.5 times the baseline in both T3 and T4 levels after the TRH.
So any noticeable increase means the thyroid is working?
Essentially, yes. If you see any clear increase, it tells you the gland is responsive, which effectively rules out primary hypothyroidism. Some horses might cough or twitch a bit right after the TRH, but that usually passes very quickly.
Okay, so summarizing the thyroid testing then. Basal, T3, T4 are screening tools, kind of variable.
Right.
But FT4D and the TRH stimulation tests are really the keys for confirmation.
Exactly. Relying only on those basal tests, that's where misdiagnosis and unnecessary treatment can happen.
This feels like a good place to talk about that silent mimic you mentioned earlier, non-thyroidal illness syndrome.
Yes, NTIS, also called sick euthyroid syndrome. This is a huge factor we have to consider.
Because sick horses often have low thyroid hormones, even if their thyroid gland is fine.
Precisely. The body seems to deliberately lower circulating thyroid hormone levels when the horse is systemically ill. It's a response to the illness itself.
So the thyroid isn't broken, it's just reacting, like you said, the canary in the coal mine.
That's a perfect analogy. And we were misreading the signal for a long time. The pattern is usually that T3 levels drop first, even with mild illness. Then, as the illness gets more severe, T4 levels start to fall too.
And TSH levels, the signal from the pituitary.
Crucially, in severe NTIS, TSH often stays inappropriately normal, or sometimes even low. This points towards a central regulation issue, the body dialing things down, rather than the thyroid gland failing.
That's a massive distinction. So clinically, what does this mean for vets and owners dealing with the sick horse?
Well, studies have shown that low T3 and especially low T4 levels in sick horses correlate with increased morbidity and mortality, higher chance of complications, or a worse outcome.
So the levels tell you how sick the horse really is, not that it has a thyroid problem per se.
Exactly. They become valuable prognostic indicators for the underlying non-thyroidal illness. It helps gauge severity.
So the biggest mistake would be
jumping straight to thyroid medication when you see low levels in a sick horse without doing further checks like FT4D or TRH stim or considering NTIS.
Because NTIS is much more common than actual hypothyroidism.
Far, far more common. Treating NTIS with thyroid hormones is inappropriate, won't fix the underlying problem, and could even mask how serious the main illness is or cause side effects.
So instead of treating the thyroid number,
you use that number to understand the severity of the real problem and guide treatment for that illness more effectively. It's about treating the cause.
Okay, that makes sense. Now, beyond NTIS and actual thyroid disease, you mentioned other things can mess with these hormone levels too.
Absolutely. Lots of things. Medications are a big category.
Greek steroids.
Definitely. Glucocorticoids can lower thyroid hormone levels. Also, phenobutazone, butadiene NSAID, and even some antibiotics like trimethoprim sulfas. You really need to know the horse's medication history.
And what about pergolide, the PPID medication? I've heard people worry that affects thyroid levels.
That was a theory, but actually, recent research shows pergolide does not seem to negatively affect thyroid hormone levels in healthy horses. So that's one common assumption debunked.
Good to know. What else influences the numbers?
Well, age is a big one. Newborn foals have way higher T3 and T4 levels than adults, like maybe 14 times higher for total hormones, 5 times for free T4. These drop naturally in the first week.
So a foal's normal is totally different.
Totally. Then there's environment and diet. Horses living outside in winter tend to have higher baseline T3, T4, probably adapting to the cold. Diet matters too. Fasting can lower levels. High energy, high protein, even high zinc or copper diets have been linked to lower measured levels. And iodine is critical. Too little or too much, maybe from supplements like kelp during pregnancy, can cause goiter in foals.
Wow. And exercise.
Strenuous exercise can also decrease measured thyroid hormones. And here's a really important counterintuitive point. Giving thyroid supplements to healthy performance horses thinking it'll boost them.
Yeah.
Bad idea. Studies show it can actually lead to them tiring quicker and increase the risk of heart arrhythmias. It's definitely not performance enhancing and can be dangerous.
Okay, so that whole list, meds, illness, diet, climate, age, exercise, it makes diagnosis really challenging.
It absolutely does. It means a low thyroid reading is much more likely to be due to one of these factors or the severity of an illness than a primary thyroid problem.
So you really need the whole picture.
A holistic approach, full history, meds, diet, environment. It's puzzle solving, not just looking at one number.
Okay, let's switch gears now to the pituitary gland, the master conductor.
Good term for it. It's central. And the key hormone here is ACTH, adrenocorticotropic hormone.
That's the one that tells the adrenal glands to make cortisol, right?
Correct. But what's really fascinating is that TRH, the same hormone we talked about for thyroid control, it also plays a significant role in ACTH secretion in horses. And crucially, in horses with PPID, pituitary pars intermediate dysfunction.
The condition often called equine Cushing's?
Exactly. In those horses, the cells in the pars media that make ACTH become abnormally over-responsive to TRH.
And that's the basis for using TRH to test for PPID.
Precisely. That exaggerated response is what the TRH stimulation test for PPID detects.
And PPID itself, that's the most common endocrine disorder in older horses, right? Over 15.
By far the most prevalent in that age group. So yeah, many listeners will unfortunately be familiar with it.
What's actually happening in the pituitary with PPID?
It starts with damage, likely oxidative stress, to specific neurons in the hypothalamus. These neurons normally release dopamine, which acts like a brake on the pars intermedia part of the pituitary.
So the brake fails.
Exactly. You lose that dopamine inhibition, and the pars intermedia cells start multiplying. That's hyperplasia, and pumping out way too much ACTH and related hormones uncontrolled.
Yeah.
Eventually, this can even lead to actual tumors, adenomas.
And the signs we see, they start subtle.
Often very subtle early on. Maybe just shedding their winter coat a bit late, or some mild muscle loss you can barely notice. But, and this is critical laminitis, especially showing up in late summer or fall.
Yeah.
That could be a very early warning sign. It's often triggered by the natural seasonal rise in ACTH, getting exaggerated in these early PPID horses.
Okay. And the more classic advanced signs.
That's when you see the really obvious things. Hirsutism, that long curly coat that just won't shed.
Yeah.
Excessive or weird sweating patterns. Bulging fat pads above the eyes. Drinking and urinating a lot. Polydipsia, polyuria.
Yeah.
Infertility. And sadly, recurrent laminitis is very common. Plus lethargy. Significant muscle wasting, especially over the top line, and that sort of pot-bellied look.
And they're prone to infections.
Yes, chronic or recurrent infections are a big problem. And many develop insulin dysregulation too, which complicates things further.
So connecting that bigger picture, PPID isn't just one thing. It's this complex, progressive neurohormonal issue with huge system-wide effects.
Absolutely. Metabolic chaos, laminitis risk, weakened immunity, that potbelly and muscle loss, direct results of too much cortisol signaling, breaking down protein.
Which really underlines why catching it early is so important.
Definitely. Early diagnosis and starting management can help slow things down and hopefully prevent or lessen those severe secondary problems that really impact their quality of life.
So how do we diagnose it reliably? Clinical signs plus tests?
Yes, it's a combination. The specific test often depends on how advanced the signs are and even the time of year.
Okay, what's the main baseline test, ACTH?
The basal endogenous ACTH test is a cornerstone. It's a single blood draw, but the handling is absolutely critical.
Oh, so
Blood has to go into an EDTA tube. The purple top one be gently mixed and chilled immediately, like on ice. Then the plasma needs to be separated from the red cells quickly, ideally within 4 hours.
okay.
Then that plasma goes into a plastic vial and must be shipped frozen on dry ice. ACTH degrades easily with warmth or delay. Oh, and no fasting. Needed fasting can actually lower ACTH.
Keep it cold and fast and interpretation. Seasons matter hugely.
Hugely. ACTH levels naturally rise in the autumn in all horses. So a high level only suggests PPID if it's above the reference range for that specific time of year.
And other things can cause high ACTH too.
Yes, stress, excitement, intense exercise, even severe illness can cause temporary spikes, so you can get false positives. In a very early PPID, the basal level might still be within the normal range, a false negative, so it's not perfect, especially early on.
Which brings us back to the TRH stimulation test, but this time for ACTH response.
Exactly. This test is known for being more sensitive, especially useful for those early or borderline cases where the basal ACTH isn't clear-cut.
And the protocol is different from the thyroid TRH test.
Similar concept, but different timing. You take a baseline EDTA plasma sample for ACTH, give the TRH intravenously, then, and this is crucial, you take the second blood sample exactly 10 minutes later.
10 minutes, got it. And timing of year matters here too.
Yes, ideally you do this test between mid-November and mid-July. You want to avoid that natural autumn rise in ACTH confusing the results.
So what are you looking for in the results?
In a PPID horse, that TRH injection causes an abnormally large, exaggerated spike in ACTH at that 10-minute mark, much more than you'd see in a healthy horse. When monitoring treatment, you hope to see that post-TRH level come down compared to the initial test.
Okay, now you mentioned a shift, the dexamethasone suppression test, DST. It's not recommended anymore.
That's right. Some major guidelines now explicitly state it's no longer recommended.
Why the change? It used to be common.
Several reasons. It's more complicated to perform. It's actually less sensitive than measuring ACTH directly, especially with the TRH test available now. And importantly, there's a real risk of it triggering or worsening laminitis in horses that might also have insulin issues.
Ah, the laminitis risk. That's significant.
It is. Plus, you can still get false positives or negatives with it. The newer methods are just safer and generally more reliable.
So the whole diagnostic approach has really evolved. Basal ACTH, TRH DIM for trickier cases. It's moved towards safer, more direct tests.
Definitely. It means vets really need to stay current, as the best practices do change based on new evidence.
And underpinning all of this is getting the sample right. We touched on it for ACTH, but it applies across the board.
Absolutely critical for all endocrine tests. Bad handling equals bad results, period. ACTH degrades with heat. FT4 reads falsely high if heated. You mess up the collection or storage, the numbers you get back might be meaningless or worse, misleading.
So give us the key rules for handling samples.
Okay, generally, no primate samples near equine ones, obviously. Don't send whole blood.
Yeah.
Avoid serum separator tubes, those gel tubes that can interfere. Label everything clearly.
Right. And for serum, like for T4?
Let it clot properly, spin it down in a centrifuge, carefully pipette the serum off into a plain, non-additive tube, and then freeze it or ship it chilled, according to the lab's instructions.
And for plasma, like ACTH, the super critical one.
EDTA tube, purple top, gentle inversion to mix, immediately chill it. Ice water bath is good. Spin it down and get that plasma off the cells fast, ideally within 4 hours, faster if possible. Transfer the plasma to a plastic vial, freeze it, and ship it on dry ice. No exceptions if you want an accurate ACTH.
Precision matters, but it's not just the sample handling, is it? The horse's history is vital, too.
Equally vital. You absolutely need the full context. Age, sex, current meds, what clinical signs the owner is actually seeing.
Why does the lab or the vet need all that?
Because that's how you interpret the numbers correctly. Knowing the context helps you account for all those confounding factors we talked about, NTIS, seasonal changes, drug effects. It turns a number into a diagnosis. Without the history, you're interpreting in a vacuum.
Okay, makes sense. Let's briefly touch on treatment. For that rare adult horse with true hypothyroidism,
prognosis is generally pretty good with thyroid hormone replacement exogenous T4, usually dosed around 20 micrograms per kilo per day.
But foals with congenital hypothyroidism,
unfortunately, the prognosis there is often poor because of the severe bone and joint problems they usually have. They typically need intensive care.
And for PPID, treatment is medication and care.
Yes, the main medication is pergolide, usually somewhere between zero point 0.5 and 2 milligrams per day, adjusted based on response. Plus good general management, dental care, hoof care, nutrition. But it's lifelong management, not a cure, and the prognosis varies.
Are there times you absolutely should not give thyroid hormone?
Yes, critically. Do not give thyroid replacement to horses that have low T3 or T4 simply because they have NTIS, that sick euthyroid state from another illness. It won't help and could make things worse.
So you need that confirmation testing first.
Absolutely. Provocative testing like the TRH stim is essential before starting treatment in any horse suspected of hypothyroidism if they're sick or debilitated from something else. Also, remember that giving external thyroid hormone can make the horse's own thyroid gland lazy, even shrink. So if you ever stop it, it needs to be tapered off gradually.
And pergolide has potential side effects, too.
Overdoses can cause loss of appetite, lethargy, sometimes stumbling, or in-coordination ataxia. So monitoring and dose adjustment are key.
How often do you retest?
For thyroid supplementation, recheck serum T4, T3 maybe every 30 to 60 days initially to adjust the dose. And a key point, if a horse doesn't improve clinically after about 6 weeks on thyroid meds, you really need to question if the diagnosis was right in the first place.
Right. And for PPID monitoring?
Retest endogenous ACTH, maybe every 3 to 5 months or sooner if signs change, to guide pergolide dose adjustments.
Okay, so wrapping up this deep dive, we set out to navigate these complex tests, hoping to empower you, the listener, with better understanding. Key takeaways seem to be: true primary thyroid issues are rare, NTIS is common and confusing, and PPID diagnosis has really shifted. We need to move past old assumptions.
That's it, exactly. And maybe the final thought for you to consider is, what's next for you in understanding this balance? How might this change how you look at subtle signs in your horse or interpret those test results?
Yeah.
Will it make you ask more questions, look a bit deeper? Because the most valuable knowledge isn't just having it, it's understanding it and using it. Keep learning, keep thinking critically for these amazing animals.